and Gynecology of Canada. He's also received Chesley Award from International Society for the Study of Hypertension in Pregnancy in 2014. He's also received Presenter's Award from Society for Gynecological Investigations, USA, in 1998, and many more. For such an accomplished awardee, I think he deserves a hand. So Dr. Peter Von Dadelszen, sir, please carry on.
Thank you very much. And I think I should start my presentation with apologizing to Dr. Gowda for not having been here during the preeclampsia session yesterday, but there was a meeting at the RCOG in London that I had to attend, so I'm late, and I apologize, but it is wonderful to be part of this event. So we're talking about preeclampsia again, and you probably went through this more than once yesterday, and the classical definition of preeclampsia is confined really to hypertension and proteinuria, however significant proteinuria is defined. But that classic definition doesn't recognize the systemic nature of preeclampsia, and it's therefore, more importantly, its wider impact. And although we use hypertension and proteinuria to make a diagnosis, and although women with severe uncontrolled hypertension, I hope you noticed the cradle device, Nicola, in the image, that's the consequence of uncontrolled hypertension. More women die from acute renal failure, eclampsia, stroke, and DIC and abruption and pulmonary edema than die from proteinuria. And unless we think of preeclampsia as a systemic disease with multiple target organs, then I think we confine women to poor outcomes. So the IHME estimate from 2 years ago now estimates that there are 30,000 maternal deaths related to the hypertensive disorders of pregnancy. However, field data from Pakistan, from the AKU group, imply that up to 40% of maternal deaths from PPH are symptomatic for hypertension in terms of, if you undertake a verbal autopsy, symptomatic in terms of headache, epigastric pain, abdominal pain, painful bleeding, prior to presentation at facility, because they're the women in this bottom right-hand corner who have maybe had an abruption, and by the time they get to facility, the cradle device is going to tell you that they're in shock and they've got a positive shock index. So they arrive in facility labeled as postpartum hemorrhage because no one's ever discovered that they were hypertensive. So it may be that up to 40% of the 40,000 deaths attributed to PPH are actually related primarily to the HDP, and therefore the burden of death may be as high as 46,000 maternal deaths annually. That's at least one woman every 11 minutes somewhere on the planet. And over 99% of those will occur in less developed countries. They're estimated to be at least 500,000 perinatal deaths annually, or 5 lakh if you would like me to speak in Indian. And that's the equivalent of about 1,500 deaths in total per day, or 4 A340s, Airbus 340s crashing daily with all souls lost. In Canada, here in Karnataka, there is no word for preeclampsia. There isn't in Shangana, there isn't in Sindhi. There is often for eclampsia, but not for preeclampsia. It's a concept that hasn't made it into communal thought processes and language. And as I said, over 99% of these deaths are occurring in less developed countries, primarily to delays in triage, transport, and treatment. And probably about half of the deaths are occurring at home. So within PREEMPT, which stands for preeclampsia, eclampsia, monitoring, prevention, and treatment, because that's how the acronym works, there are 5 objectives in terms of prevention, and I'll briefly touch upon that because Justice gave the calcium and preeclampsia talk yesterday. Monitoring treatment, and I'll touch again across about the global CLIP pardon me, trials rather than solely the Indian focus that Dr. Balad had yesterday. The global pregnancy collaboration and knowledge translation. They're the 5 component pieces of the Gates Foundation initiative. So Justice described the prevention process yesterday through the calcium and preeclampsia trial. What is interesting, I think, Justice, is that my understanding in rural Mozambique is that the amount of elemental calcium in their diet is less than 350 milligrams a day. And through the community surveillance in the CLIP trial, which I'll come to in a moment, through with the PIERS on the Move devices, we're detecting a rate of pregnancy hypertension of 7 or 8%, which is almost twice the other 3 countries. So maybe you are after something after all. I'm the skeptic who provides equipoise on Justice's trial steering committees. I'm not sure calcium's going to work for preeclampsia, though I think it's really important for populations. So that's as much as I'm going to say about calcium, because you heard from an expert yesterday and I wouldn't claim to be one. In terms of monitoring, I want to talk about the miniPIERS project, which is, PIERS stands for Preeclampsia Integrated Estimate of Risk model. And this is a model for time of disease risk estimation in women with pregnancy hypertension. And we developed the model in Suva, because I'm originally from down here in New Zealand. I can close off my nasal passages and sound like a Kiwi if you like. In Karachi, Kampala, Cape Town, and Sao Paulo. And why PIERS? Well, mainly because there's a little academic game that my wife and I play that we name projects after children. And this is PIERS. He's now 6'4", and that's Nonu in the 2011 World Cup, because I took him home to New Zealand to watch some rugby. So why worry about time of disease risk estimation? One of the holy grails in obstetrics is the prediction of preeclampsia. There are lots of people spending lots of money and lots of time on it. But the best evidence we have is that standardized assessment, standardized care for women with the HDP, especially preeclampsia, improves outcomes. And the best data we have to support that are the data from the confidential inquiries in the UK. And if we look at from the first triennial report, 1952 to 54, all the way out to the 2006-2008 triennial report, there was a 90% reduction in total deaths, this is absolute numbers, attributed to the hypertensive disorders of pregnancy. It's since halved in the last few years, but which is because of addressing severe hypertension, we think. So effective antihypertensives were introduced into maternity care in the UK in the mid-70s. And Lelia, I was at the RCOG when you and Jack Moodley presented the collaborative eclampsia trial, which I walked in a phenytoin user and I walked out a magnesium user, which changed practice in the UK overnight. And if you notice, the blue bar columns do suddenly decrease thereafter. So I think it did have a direct effect. But 90% of that observed reduction in mortality occurred prior to those 2 interventions, and it was related, I believe, to surveillance, making a diagnosis, timing a delivery because you recognize when the woman is doing poorly, and also giving women reproductive choice, so choosing when to become pregnant and if they wish to remain pregnant. So the PIERS combined adverse maternal outcome was developed by international global Delphi consensus, and it is a list of outcomes of varying severity from blood transfusion all the way through to maternal mortality, but they're all outcomes that I, as a practicing obstetrician, wish to avoid. And that was the consensus that we came to. And what we did is we developed the model in those with about 1,800 women and ended up with a model that includes parity. So if you're nulliparous, you are more likely not only to develop preeclampsia, but to suffer personal adverse consequences of preeclampsia should you get it. Gestational age, the longer you're pregnant for, the less likely you are to develop the complications of preeclampsia. The symptom complex of chest pain or dyspnea, or maternal headache or visual disturbances, and maternal abdominal pain with bleeding, systolic blood pressure, and dipstick. And why the focus on systolic? The focus on diastolic for chronic hypertension for a long time, and I think people took their eyes off the ball. In terms of acute risks of stroke, systolic is far more important than is diastolic blood pressure, and it's been under-responded to, I think, globally. And also, you only need a finger and a sphygmomanometer to take a systolic. You don't have to learn how to listen to cough sounds. So with that, but that was before the cradle device, of course. But and then dipstick proteinuria is in the model not because it adds anything to maternal safety. The beta coefficient is minimal. It doesn't have a significant independent p-value, but it was there for face validity because we didn't feel that the global community was ready to abandon it yet, and also because it was highly predictive of neonatal mortality and for fetuses who were known to be alive on admission to facility. But what happens then if you add pulse oximetry to the miniPIERS model? Because in Vancouver, there's a group who have developed a pulse oximeter that's as accurate as anything that you can buy that costs thousands of dollars for under 20 and plugs into a phone. Here's the area under the receiver operator characteristic, which is about 0.77. And if we look at women who have a highish probability of an adverse event, that's above 25% individualized risk for an adverse event, we'll identify 65% who go on to have one. We add oximetry, the area on the curve doesn't change significantly. So don't always be lulled into comparing ROC curve analyses because they don't always give you the whole picture. But if we use the same high-risk group, by adding oximetry, we now identify 85% of women who will go on to have an adverse event. And we haven't taken a blood test. It's demographics, symptoms, and signs, if you call oximetry a sign. You can then place your algorithm into a mobile health app, which is called PIERS, or the POM app to its friends, and then you can, by making sure that these are the Nigerian pictograms, make the model user-friendly and sort of intuitive to develop and put into a device to guide care. And here we are talking about magnesium sulfate in the context of the CLIP trial, and I'll briefly touch on that again. So that does lead us to it. So I know Dr. Ballard talked about this yesterday. There have been 4 trials. The trial in Nigeria has actually has been converted into an implementation study due to surveillance issues. Initially by feasibility studies led by Rahat Qureshi at AKU and myself, and we did this complex process to work out over a year in each of the 4 countries what the barriers and facilitators would be to conducting the trial in each setting. And these are going to be published in a series of supplements to BMC Reproductive Health. So implementation study now only in Nigeria, but in Sindh, Karnataka, and Maputo and Gaza provinces, we're going to be recruiting now, we think, about 60,000 pregnancies. And what I have to do is take my hat off to the Gates Foundation, who, when we were designing this initiative, insisted that each of the country trials be independently powered for our primary outcome for the trials. Because losing over a quarter of our data set in Nigeria would otherwise have been catastrophic. So it was actually Gary Darmstadt who insisted, and I had the opportunity to thank him at a meeting in Delhi just before Christmas, and I was very effusive in my thanks. So this is where we are. So in the pilot trials, we actually recruited about 10,000 women in Nigeria, but we can only use the POM data from that experience. In Pakistan, there are about 4,300, and here in India, about 2,200 women in the pilot trials. In Nigeria, they've been using the new version. There's Andy Shen. I don't know if you showed that photo of Andy Nicola with the cradle device. And he does usually actually smile that broadly. And there's a pictogram from Mozambique showing the device in use. Oops. Oh, there we go. Okay, so therefore in the CLIP trial in Nigeria, we added the shock index and a diastolic threshold for urgent referral, going back to the interventions that Dr. Balad described yesterday. And again, so that a severe diastolic hypertension also became a trigger for magnesium usage in Nigeria, whereas it isn't in the 3 countries that are continuing in the trial. We've also had additional diagnostic performance with the phone oximeter, and in Karnataka in Sindh and Maputo and Gaza, they're actually adding oximetry to the platform to see what the incremental value of the oximeter is in terms of your outcomes for the trial. So again, an oxygen saturation of less than 93% becomes an additional trigger in those 2 settings. So where are we at? So Mozambique, going west to east. Mozambique started, and also in reverse order, on the 15th of February last year. Pakistan started the definitive trial on the 18th of January, and India started on the 1st of November 2014. The trial at the moment will end here on the 31st of October. But the advantage of running these now 3 trials on the same platform using what is the same intervention that's been tailored in response to the feasibility studies for purpose. So each trial does become a national trial because there are variations where the emphases have been placed. We will then end up with a 60,000 pregnancy trial, and we'll be able to pull the CLIP primary outcome apart and at least hopefully get some important information about maternal outcomes and maybe even maternal death, though we may be will probably now be underpowered for that, as an outcome in the IPD meta-analysis, which I think is a great strength of what the foundation empowered us to do. The other thing that we're doing in the treatment part of PREEMPT is a head-to-head comparison in 2 centers in Nagpur of 3 oral antihypertensives. So the 3 oral antihypertensives that we're using are nifedipine, labetalol, and methyl-dopa. And you'll be methyl-dopa for severe hypertension. It seems counterintuitive, but in fact the time of onset for a woman for methyl-dopa in a woman who's methyl-dopa naive is about 40 to 60 minutes, which is the same as oral labetalol, which is actually the drug of choice according to the NICE guidelines in the UK, though the RCT support for that's a bit lacking. So they've been through the pilot phase and found there has systolic blood pressures. These are open label, 10 consecutive cases that nifedipine brings blood pressure down from systolics around the 150 to 190 mark down, but some maybe overshooting a bit. Labetalol seems to have a similar effect, though these women don't seem to be quite as unwell. And methyl-dopa, maybe not as effective, but this woman actually had more doses of nifedipine than she had of methyl-dopa because it was open label and she just had intractable hypertension. So it took about a year to get through the ICMR and the DCGI process to get the trial up and running, but it has started. Sorry, that's from last October. So we are now well into recruitment, and the primary outcome is going to be in-range blood pressure, so not severe hypertension, but also not hypotension, without other adverse outcomes such as hypotension, a section for fetal distress, severe headache, or requiring discontinuation of the drug, or eclampsia. So those are the sort of the trial aspects or the clinical study aspects of the initiative. The other piece to it is the Global Pregnancy Collaboration, which is a consortium of now at least 35 academic centers who are sharing clinical and biological data or actually biological samples that they have biobanked to accelerate knowledge in the field of preeclampsia and other pregnancy outcomes primarily related to the placenta, to try to accelerate knowledge generation. This is an approach that's been used extensively in cardiovascular and cancer disease, and the new revolution around ovarian cancer, maybe having most of its origins from tubal disease, come from such a collaboration. So we're pooling resources and we're trying to accelerate knowledge generation. The problem is nearly all of these 35 centers and their data and their biological samples have come from places that have people who sound like me. And we have a huge paucity of biological specimens from women in the countries where women are dying. And we do not know for certainty that the pathways to preeclampsia, to growth restriction, to stillbirth are the same in India, Vietnam, or Latin America as they are in North America, Europe, Australasia, whence most of the data have been derived, and upon which we're basing these interventions. So we need to do better than that. And there's a plea out there for increased collaboration and participation. And the final piece is that we've got a mandate to improve knowledge translation. So what we know into the practitioners at a global level. And the thing we did on that front was with USAID sponsor the update of the WHO recommendations for the prevention and treatment of preeclampsia and eclampsia. And that's, I think, was a major step forward, and the plan is to undertake that exercise at the end of Preempt to inject the learning from Preempt into an updated set of recommendations within the next couple of years. We're also helping to support the Preeclampsia Foundation, which is a global peer support group for women and families that have been affected by the condition. And the final thing that's going to be launched at the World Congress of the RCG is a textbook of the hypertensive disorders of pregnancy. Is actually going to have the imprimatur of the FIGO. It's going to be the FIGO book of pregnancy hypertension. Our long-term goals are to hopefully prove that this approach works, and then we'd like to take the same the life-ending, altering, and threatening conditions that bedevil women, especially in less developed settings. I need to acknowledge the support, particularly of the Gates Foundation, but we have had support from other funders that have strengthened the initiative. But the most important people are all the people who do the work, because I'm just maybe a bit of a thought generator, but I have done very little of activity, and I'm very grateful. across the world. And background of this photo, which is a photo of usher workers in one of the Belgaum clusters, Bagwakot clusters, with their pairs on the move phones, holding up their pairs on the move apps as part of the CLIP trial. And I just want to say thank you.